well. Only one. In fact, for the ovaries, only one. The rest, I think the surgeons or the obstetricians will deal with them effectively. The ones that are most likely going to reach on your desk will be the carcinomas. Carcinomas, you have to know. When you're talking about a female or a female predominant carcinomas, ovaries and breasts stand out. In fact, I think by 2014, breast carcinoma might have overtaken lung carcinoma as the predominant death-related cancer in the female gender. Breast carcinoma, the risk factor is very, very high. We are talking of 1 in 8 women will most likely end up with some form of breast carcinoma. Breast cancer is again not one disease, as we are going to see. That when you meet a patient, you have to know why are we treating this patient differently from the previous patient. It is not one disease. It might look like one disease, the way the newspapers put it outside there, the way everybody talks about it, it is not one disease. I'll try as much as possible not to pin you down on the finer details of the histology and just give you a broad picture. My presentation is also full of mainly images so that I can illustrate for you, easily illustrate for you what I'm referring to. When I send you the notes, I'll add more meat, more description to the slides. But for now, it's mainly tables and pictures so that we make it as short as possible. If you don't remember much of what I'm going to say for the next at least 1 hour, please remember, for the ovaries, we don't worry so much about inflammation or development abnormalities. We worry mainly about ovarian carcinoma, and it's only one that is the predominant. And when anybody is referring to ovarian carcinoma, they are referring most likely to that subtype. Now, for the breast carcinoma, I'm going to avoid the histology and concentrate more on how we make the final decision on the management. What do we need? What must we do? So when this patient is coming to you and you are giving them tamoxifen, why are you giving them tamoxifen? It's not because of the histology. Why is this patient on HER2 inhibitors? It's not because of histology. And that's why I'll avoid the histology and go straightly to what we call the molecular subtyping, because the molecular subtyping is how we manage our patients with breast carcinoma. Okay, now, so how bad is breast carcinoma and ovarian carcinoma? You can see this is 2014 United States figures. Breast is top of the list. I'll give you what the Kenyans have. This is for the new cases. This is new cases, incidence. This is not prevalence, this is incidence. Now, this is the estimated deaths. You can see lung and bronchus tends to be top on the list for both male and female. Breast is just there. This is USA. We're assuming their therapy, their management, their diagnostic style is much more advanced than ours. Ours could be worse because, again, I'm going to show you, we have the worst form of breast carcinomas among most of the, I don't know how many races we're supposed to have in the world. If you assume 4, then we have the worst, our cancer, the form that we have around here, and the form that tends to affect the younger women has a worse prognosis than most of the other breast carcinomas. I'm going to show you that. Okay, so breast carcinoma is very high in terms of the incidence, also in terms of the death rate or cancer-related deaths. Ovarian is also there. Okay, let me get this. Ovarian is there. So we are talking about on the top, among the top 10 cancer in women, we are talking about 2 of them today. Okay. We'll also see why ovarian carcinoma death is very high. You are not seeing the incidence here. You can see here incidence is low, but the deaths are pretty high for ovarian carcinoma. We'll see why that happened. We'll see the reason why ovarian cancer, despite not being having a very high risk, very high prevalence like colorectal, but still kills more women than any other carcinoma. This is 2020. 2020 on the world now. This is for the world. Yes, you can see breast is still top of the list. Ovary is there for women. Okay, very high. This is men and women. Even if you combine men and women, breast is still extremely high. Still extremely high. Okay. This is Camry. This is 20. This is 20. This is 2020. This is 2020. Cancer burden in Kenya. Cancer burden in Kenya. This is the total mortality in the whole world. So cancer deaths actually is pretty high. The top 10 female cancers, breast and ovary are also here. This data should be for only, I think, only Nairobi. We don't capture our data very well because, again, we don't have a centralized data registry, and then we are a bit fragmented on the way we capture our cancer. But even from this infographic, you'll see that breast and ovary are pretty common. Okay. Now, for the typical female reproductive system outline, I'm very sure you've discussed the cervix, you've discussed uterus, you've mentioned something about the fallopian tube. Now you're going to go to the ovaries. And the ovaries, they are mainly tumors. We don't see infection so much in the ovaries. And if the infection is most likely, the common one is just the tube ovarian abscess related to pelvic inflammatory disease. Okay. So for the tumors, there are usually 2 types. There are 2 types of masses that you'll see in the ovary. They are what we call functional. Functional or non-neoplastic means they are not tumorous. They are not neoplastic. It's a mass, yes, but it's coming from a failure in the involution of a cyst that is supposed to involute. Like, for instance, a follicle cyst, once the egg is discharged, it's supposed to involute. A corpus luteum, once it's discharged and there's no pregnancy, that corpus luteum is supposed to shrink, but sometimes they remain. So when you talk about non-neoplastic, basically means they are not tumorous, they are not, there's no genetic abnormality, there's no cancer hallmarks in the cells. It is just a problem with the involution, more of just the hormones. Tumors now means they are neoplastic. Yes, they are neoplastic, they are clonal, and they can be benign, or they can be malignant. So there are 2 forms of the ovarian lesions, tumors, and also non-neoplastic and functional cysts. Yes. So non-neoplastic and functional cysts, we can have follicular cysts. Then we mentioned something about PCOS, polycystic ovarian syndrome. Then you have luteal cyst. Then you'll have endometriotic cysts. These are not cancerous. These are not tumorous. These are most likely non-neoplastic and what we call functional cysts. So follicular cysts Basically, they are very common in the ovary. They originate from an unruptured follicle, or in a follicle that has ruptured and immediately sealed. These are simple non-neoplastic lesions. Or you can have a luteal cyst. Okay, these are cysts like once the ovary is discharged, not the ovary, the egg is discharged. Once the ovary is discharged to the fimbria of the fallopian tube, this corpora lutea or corpus luteum is supposed to involute. Those come smaller, but these ones they persist. And when they persist, they can become hemorrhagic, they become larger, they become cystic, they can even rupture and mimic an ectopic pregnancy. You know that if there's a pregnancy, it is the luteal cells that are supposed to maintain the pregnancy by producing progesterone. If there's no pregnancy, the corpus luteum is supposed to become smaller, involute, and disappear and change into corpora albicans. If that does not occur, the cyst remains. This is a simple cyst, very clean, thin wall, nothing inside, there's no growth. This is typical of a follicular cyst. This is not cancerous. In fact, even if you confirm radiologically that what you have there is a follicular cyst, we normally don't bother with them. Some of them can be symptomatic, but unlikely to be symptomatic. This, you can see this one, this is a cyst. They can become big from 1 centimeter to 3 centimeter. You can see the attached fallopian tube. And even this one looks almost transparent. Thin wall, very benign. This is a benign lesion. This is a follicular cyst. It is not cancerous, it's not tumorous. Yes, and it comes, even if when you excise it, comes out actually very nice. This is a follicular cyst. Non-malignant, non-tumorous, mainly a problem with hormonal changes and developmental changes in the oocyte cycle in the ovary. This is a luteal cyst. Luteal cysts normally they're a bit thick walled. You can see this yellowish rim because of the luteal cells are normally full of lipid. And they're a bit thick walled and they are hemorrhagic. So this one can rupture and give you, a hemoperitoneum, can actually mimic an ectopic pregnancy. But again, these are not cancerous, these are not neoplastic, these are functional cysts, very common. Okay. Now, we are mentioning this because polycystic ovary is when you have multiple follicular cysts. Polycystic ovary is a little bit different. Okay? I'm mentioning this because there are high chances you are going to meet a young girl with this condition. You can see the prevalence. Basically, we are saying 1 in 10 don't count to call them women. They are more of girls, teenage girls, now going to women, have this condition. And what is this condition? You can say it occurs during teenage and childbearing years. It is a complex disorder in that it's not just the ovaries alone that are involved. There's also the metabolic component. There's also the issue of insulin resistance. There's also the issue of very high androgen levels, very high estrogen levels, anovulation involved there, and on top of that, obesity. How does it reach there? Let's look at the pathogenesis first. Okay. Now, what happens that there's a change in the hormone, in the gonadotropin-releasing hormone secretion. And then there's a change in the ratio of LH to FSH. So if there's too much LH, what happens is that you end up with the excess production of androgens. Because normally when you want to make estrogen, you make androgens first. then you convert the androgen into estrogen. So if that is not done, or if that one fails, what happens that you end up with excess androgen. And when you end up with excess androgen, you cause follicular maturation arrest, so that the maturation of the follicles is not there. And if the follicles don't mature, they don't proceed to Graafian follicle. They don't release an egg or an ova. So if an ova is not released, that is normally termed as an ovulation. If there's no ovulation, if there's no ovulation, you don't form sufficient progesterone, because progesterone normally comes from the corpus luteum. Corpus luteum. So if you don't form corpus luteum, yes, so basically you don't have progesterone. And if you don't have progesterone, the predominant female hormone that will be there will be estrogen. So in this case, you have a situation of a patient who has excess androgen. They also have excess estrogen. And on top of that, this excess LH, okay, and the excess LH and the excess androgen will cause what's called altered steroidogenesis. The steroid hormones, in fact, also in the adrenal cortex, will be abnormal. If you have altered steroidogenesis, the end result is that you end up with a patient who have excess androgen, a patient who has excess estrogen, and a patient with very low progesterone. So the effect of PCOS that I will be here will be because you have excess androgen, you have excess estrogen, you have low progesterone, and on top of that, you have insulin resistance. When I show you this patient, most likely you'll be able to identify one or two. And this one, you're going to meet them. They are there. Okay? So what happens, the endometrial hyperplasia that you see here is because of excess estrogen. Okay? You have what is called anovulation. And if you have anovulation, you'll have abnormal menstruation. Either there'll be very few, if there are very few menses, forgive me for using that term, normally the term we use is oligomenorrhea. The menses take longer, not monthly, they come even irregularly, they come even after 3 months. That's called oligomenorrhea. And because for you to have sufficient progesterone, yes, in the what's called the luteal phase, a corpus luteum has to be formed. If a corpus luteum is not formed because of the maturation arrest, what you end up is that the follicle, the luteal, the follicles become multiple and they become smaller. So at the end result is that you have an ovary that has multiple follicular cysts, And that's the reason it's called polycystic ovarian syndrome. Polycystic ovarian syndrome. So these patients will present with the endometrial hyperplasia and possibly well-differentiated adenocarcinoma because they have excess estrogen. They'll have acne, obesity, hirsutism, insulin resistance, and possibly diabetes because of excess androgen and insulin resistance. Okay? Let me show you the picture here. So typically, this is how our patient will appear. They'll have hair loss. The hair loss is because of excess androgen. They'll have hirsutism because of excess androgen. They normally have pelvic pain because of anovulation and oligomenorrhea. They'll be overweight because of insulin resistance and metabolic syndrome. We have talked about acne. Acne is because of excess androgen, irregular periods, anovulation, low progesterone, high in androgens, high estrogen. They'll have infertility. because they are not ovulating. The cycles they're having are infertility. They'll have high testosterone level because of the changes in the LH and the FSH. In that, we already told say that if you want to make estrogen, you make androgens first. And the androgens here are testosterone and epiandrosterone. So you make testosterone first. Then you convert testosterone to estrogen. And that's even what happens with the adrenal cortex. If you remember your physiology, there are two ways of how you get steroid hormones. You can get steroid hormones from the ovary, or you can get steroid hormones from the adrenal cortex. I'm mentioning this because this is common. So your patient will have oligovulation or anovulation. They'll have excess androgen activity, and when you look at their ovaries, yes, the ovary is polycystic. And that's why it's called polycystic ovaries. And the cysts that are there are mainly follicular cysts. Okay. Most likely you have seen one or two, even your schoolmates having this symptom. This is common. And there are chances that you'll be brought a patient like this and you'll be told to give them combined oral pills. And you'll be wondering why I'm giving combined oral pills to a 16-year-old who is not even sexually active. Okay. I'll skip this. This is not for you. But in this case, instead of having the cyst, it's just the ovarian stroma that is hyperplastic. Okay. You can have endometriosis. I hope you know what endometriosis is. Brimstone, you know endometriosis? Anybody who knows endometriosis? Anybody who knows endometriosis? You have not reached there.
It's a condition whereby the endometrial tissue grows outside the uterus. It grows into abnormal places.
Thank you, Timothy. Endometrial tissue outside the endometrium. It's as simple as that. So this can grow also in the ovary. And when this goes in the ovary, we call it it normally becomes cystic. It's normally called it endometriotic cyst. And they can be large. And because they are normally functional endometrial tissue, they can end up with bleeding. And the recurrent bleeding gives you this kind of material. And this is why normally they are called a chocolate cyst. Because the material that is here looks like chocolate. These are not neoplastic. These are functional cysts, endometriotic cysts. Okay. Yes, it's just bleeding. It can be fibrous. It's just bleeding. This is old hemorrhage. This is old blood. Okay. So those are non-neoplastic or functional cysts. Follicular cyst, luteal cyst, endometriotic cyst. And if you have multiple follicular cysts with those endocrine symptoms we have mentioned, then your patient has a polycystic ovarian syndrome. The neoplastic tumors of the ovary, you can group them into four. You have what we call surface epithelial tumors. We have germ cell tumors. We have sex stromal cord tumors. Then we have secondaries, metastasis to the ovary. This one is a better indicator here. Yes, so I'll improve on this. So you have the surface epithelial cell tumors, you have germ cell tumors, You have sex-cord stromal tumors. Then you have the metastasis to the ovary. And you can see the percentage. Surface epithelial cell tumors, we have serous, mucinous, endometrioid, and Brenner's tumor. These are the most common. Germ cell tumors, you have typically teratoma and geminoma. That's the percentage. Sex-cord stromal tumor, granulosa cell and Leydig cell tends to be very common. And then you also have metastasis to the ovaries. This is a typical classification of ovarian tumor. These are now neoplastic. They can be benign or malignant. These are better list. We have this epithelial type, surface epithelial cell tumors. We'll have serous, we'll have mucinous, we'll have endometrioid, then we have Brenner's. And in terms of malignancy, because we are more interested in the malignant ones. Remember at the beginning we told you ovarian carcinoma is not one disease, or ovarian cancer is not one disease. So when you're talking about ovarian, malignant ovarian tumors, which one are referring to mainly? Okay. Percentage of malignant ovarian tumors, serous tumors are the most common. So these are serous epithelial, surface epithelial tumors. Yes, followed by mucinous, followed here by endometrioid, and then you have undifferentiated carcinomas that you cannot tell which one is which. You can have clear cell carcinoma, and then you can have a granulosa cell tumor. Granulosa cell tumors, again, will show you that it's not overtly malignant. It tends to be a low-grade form of malignancy. The one that we fear most, I'm coming to it. Then remember, we also have metastasis to the ovary. So not all ovarian tumors are primary. They could be secondary. There are others, like even lymphomas, can be in the ovary. So the predominant, when somebody mentions that a patient has ovarian carcinoma or ovarian cancer, they are most likely referring to a serous surface epithelial carcinoma. They are most likely referring to surface epithelial carcinoma, the serous type. But all these types can be malignant. Whatever we have mentioned in this list can be malignant, including even teratomas can be malignant. But most of the teratomas are benign. We are coming to that. Okay? And that's why we're saying it's not one disease per se. Okay? Don't worry about that. Yes, this is a better list. This is a better list. Classification of ovarian tumors. You have surface-derived tumors. These are the surface epithelial tumors, which these are normally you can have serous tumor, you have a mucinous tumor, you have endometrial tumor, and then you have a Brenner tumor. The most common group of primary benign and malignant tumors are serous tumors. And they are the most common group of tumors that are bilateral. The cysts are normally lined by cells that are similar to the fallopian tube. Yes, and the benign one is called serous cystadenoma. Serous cystadenoma is benign. The malignant one is normally called serous cystadenocarcinoma because it is serous, it also has a cyst. So we'll call it serous cystadenocarcinoma. But current literature, we don't use the word cystadenocarcinoma. We just say serous carcinoma. The term we use is just serous carcinoma. So whether it is cystic or the solid or what, serous carcinoma, high grade or low grade. Okay. Then you have mucinous tumors. These are tumors that are lined by mucus secreting cells. They can be malignant, they can be benign, okay, and they can form something called pseudomyxoma peritonei. I'm coming to that. Okay. Then you have endometrial tumors. They are lined by tumors that look, cells that look like endometrial cells or endometrial tissue. They can be benign or they can be malignant. Okay. So we'll have a malignant endometrioid carcinoma of the ovary. We'll also have endometrioid carcinoma of the endometrium. Okay. Brenner's tumor, they're usually benign and they're lined by cells that look like transitional urothelial-like epithelium. They can be benign, but you can also have a malignant Brenner's tumor. These are surface-derived epithelial tumors. Serous, mucinous, endometrioid, and Brenner's. We'll mention metastatic because metastasis is very common. If you find a tumor in the ovary and you can't tell the histology very well, think of metastasis from the uterus, from the fallopian tube, from the other side of the ovary, and even from the pelvic peritoneum. They can also be from outside the Mullerian tumor. Mullerian basically means related to the female genital tract. We call them Mullerian. If there's something outside that, we call it extramullerian. So we can also have cancers from the breast and even cancers from the GIT, that is the colon, stomach, biliary tract, and pancreas going to the metastasizing to the ovary. And we have a term normally called Krukenberg tumor. Is a GIT tumor that has metastasized to the ovary. The term normally used is a Krukenberg tumor, typically from the gastric carcinoma. Okay. So metastasis, these are secondary malignant tumors that are coming from outside the ovary. We said 5% of them. Is 5% of them. Again, they tend to be bilateral because both ovaries are involved. Okay. Then the ovarian epithelial neoplasms, we have talked about the surface epithelial stromal tumor. This is serous tumor, mucinous tumor, endometrioid tumors. We can have clear cell tumors, transitional cell tumors, and then epithelial stromal tumors. And they range from benign to borderline to malignant. And the malignant can be low or high grade for the serous. Again, for mucinous, you can have benign, we can have borderline, we can have malignant. For endometrioid, again, you can have benign, borderline, and malignant. Clear cell tumors, again, benign, borderline, and malignant. And from transitional cell, benign, borderline, and malignant. Borderline means there are features that are, they show features of malignancy per se, but they are really low grade and indolent. They are not aggressive. Okay. The borderline tumors and the malignant tumors normally have a cystic component. Okay. The malignant epithelial tumors are referred to epithelial carcinoma. So when you're talking about ovarian carcinoma, we are referring to this group of tumors, the surface epithelial stromal tumors. And you said serous is the most common subtype, is 75% of the epithelial carcinomas and 47% of all the malignant ovarian tumors. This is serous. Yes, this is serous. Okay, so the most common malignant ovarian tumor is serous. The term serous is because the cyst normally has serous fluid. Okay, and they have a tube-like epithelium. They can be benign, borderline, and malignant. 70% are benign or borderline, 30% are malignant. And when a patient is younger, between 20 and 45 years, you're seeing mainly benign and borderline tumors. Serous carcinomas occur later, and they are related to BRCA1 and BRCA2 mutation. These are DNA repair genes and also tumor suppressor genes. We'll also see this being involved in the breast carcinomas. Okay. So ovarian carcinoma is almost synonymous with a serous carcinoma. There are other malignant ovarian tumors, but the serous carcinoma is the most common. Okay. This is a tumor. This is now not just cystic, it's also solid. And you can see some solid areas here. Okay. When you open it now, there's a cyst there and there are solid areas. So you say this is a complex lesion. This is predominantly solid and there are many. If we talk seeing a solid lesion in the ovary, normally is not a very good thing. This one has what looks like some papillary area, but it's predominantly solid. It's not nice looking. It's most likely malignant. Okay, and you look at the lining, can be a simple lining, can be a complex lining, can be a semi-complex lining. So from benign to malignant. Okay? From serous epithelial to borderline tumor, to a borderline tumor, to a malignant tumor, with now invasion in the stroma. Okay? Mucinous tumors account for 20-25% of all the ovarian neoplasm. They occur principally in middle adult life, rare before puberty, and the main driver here is KRAS mutation. KRAS is an oncogene. Primary mucinous carcinomas are not common. Even if you look at our table here, you can see very low. Primary mucinous ovarian carcinomas are not common. Okay? If you find a mucinous carcinoma in the ovary, your first thinking should be it's a metastasis. Okay? The most common primary ovarian carcinoma is serous. When you have a mucinous, most of them are metastatic lesions from the GIT. Okay? You need to exclude metastasis from non-ovarian primary tumors, especially GIT. Mucinous ovarian tumors can also give you what is called pseudomyxoma peritoni. Pseudomyxoma peritoni is when you have a lot of mucus material in the peritoneum. This is what we call mucinous ascites. They also have additions. It's basically like somebody took mucus and poured into the peritoneum. It normally can be caused from a mucinous appendiceal lesion, or it could be from an ovarian mucinous lesion. Yes, these are mucinous tumors. Again, the key takeaway here is that most of the mucinous tumors are benign. If you find a malignant mucinous tumor, then you have to rule out a metastasis from a non-ovarian primary tumor. The primary ovarian tumors are normally unilateral. The moment you see them being bilateral, then think of a non-ovarian primary tumor as a metastasis. This is a very large ovarian mass. Oh, Kivali, no, we don't. We add PCOS. For PCOS, we need the imaging and then we need the clinical history. You can see the clinical symptoms. Never just use one to make a diagnosis. Most of the time, the way you make a diagnosis, normally we have what's called diagnostic criteria. You add 1 plus 1 plus 1 plus 1, then plus 1. So we have like 5 criteria. If the patient has 3, we say this patient has PCOS. If the patient has less than 3, we say this patient most likely does not have PCOS. So for PCOS, we use clinical symptom. This was the diagnostic criteria. This is how you diagnose it. A patient has oligovulation or anovulation, so their menses are irregular. It takes like almost 3 months before the menses come. They have excess androgen, so you test for testosterone, it's very high. And then now when you do the imaging, you see polycystic ovaries. Then now you make a diagnosis of PCOS. You can see the criteria. If you have 2 of the 3 present, then you have PCOS. Yes, so that's how you make a diagnosis. This is the criteria. Okay. A very large tumor. Very large. It has been removed. It's still a very big tumor, but it's well demarcated. It looks like it didn't give the surgeon so much problems. Remember, we said the cancerous lesions are normally very difficult to cut because they invade tissues nearby and they adhere to the tissues nearby. This is not. This is coming out very clean. And when you cut it, And then you took the histology. This is a mucinous epithelium. That's a mucinous epithelium. But we also said, remember, we said mucinous tumors can also be malignant. You can see even here, this is mucin, and there are very, very many. Okay, this one now is more solid, but this is a mucinous lining. This is multicystic mucinous lining. Sometimes they can be malignant, like this part here is solid, this one is still solid. So if the moment you start seeing solid, it basically means they have a carcinomatous component to it. So again, mucinous tumors can be from benign, borderline, and malignant. Okay. Then you have transitional cell tumors. These are called Brenner's tumors. They contain neoplastic epithelial cells that resemble urothelium. They're usually benign. A few can be malignant, and very uncommon to get a transitional cell carcinoma. So just remember, for serous, the lining looks like tubal, like fallopian tube lining. That's a serous epithelium. For mucinous, the lining looks like the endocervical. It's producing mucin. Yes. For transitional, the lining looks like that one of the urothelium or transitional cell. And that's why it's called transitional cell tumors. Okay. Then our next topic is ovarian germ cell tumors. Germ cell tumors. These are derived from the primordial germ cell of the ovary. Okay. They can be benign or malignant. And if you find a young patient, if a 2-year-old girl, 3-year-old, 10-year-old, 15, 20, yes, presents with ovarian tumor, even if I have not examined them, my first thinking will be they have ovarian germ cell tumor. And the high chances that I will not be wrong. This is very common in the young. Ovarian germ cell tumors primarily arise in the young women between 10 and 30 years, but can go as low as even 2 years. We have seen 3 years with these germinomas. Okay? And represent 70% of ovarian neoplasm in this young age group. In this age group, we are most likely talking about ovarian germ cell tumors. Okay? And it's the same when you're being taught the testicular tumors. The histological subtype is almost the same, because we also have teratoma in the testes, we have a yolk sac tumor in the testes, we have a non-gestational carcinoma in the testes, we have embryonal carcinoma in the testes, we have mixed germ cell tumors in the testes. In the testes, this germinoma is called seminoma. When you reach there, remember seminoma, the histology is almost the same with this germinoma. And that's why I've put this here. Okay. Yes, so the germ cell tumors, you can have a teratoma. Teratomas tend to be cystic. They're the most common benign germ cell tumor. Less than 1% become malignant. Okay. They normally have, they form mature tissue of all the germlines. So they'll have skin, some of them will have the lung there, they'll have liver, they can have intestinal tissue, they can have thyroid tissue inside. That's what we mean by ectoderm, mesoderm, and endodermal differentiation. We can have a teratoma that's only forming one tissue. If it's only forming one tissue, normally we call it monodermal teratoma. And the commonest monodermal teratoma is a teratoma that is forming thyroid tissue. So you find a thyroid tissue in the ovary. And this thyroid tissue is functional, meaning it's going to produce the T4 and the T3. Okay. This germinoma is then common at the next one, and this germinoma is usually mainly malignant. This germinoma is malignant. Teratoma can be benign or malignant, but they're mainly benign. These germinomas are malignant. Okay, they have an increase in serum LDH, and they have the same histological picture as the testes. And this is what you get with the Turner syndrome. Turner syndrome is when a patient is born with only one X chromosome, the so-called 45 45X0. 45X0. Okay? They have a higher risk of developing this germinoma. Yolk sac tumors is malignant. It's the most common ovarian cancers in 4-year-old girl. So somebody, a child of, in fact, let me just say, a child of less than 10 years with a malignant ovarian tumor is most likely a dysgerminoma or a yolk sac tumor. They normally they have what's called Schiller-Deval bodies. I'll show you. And when you're doing serum tumor markers, I hope you know what you mean by serum tumor markers. The serum tumor marker for yolk sac tumor is called alpha-fetoprotein. The tumor marker for this germinoma is LDH. So if your patient has a mass in the ovary, they are young, you think they are malignant, you do alpha-fetoprotein, you do also LDH, and you do HCG, because HCG normally is increased in a choriocarcinoma. Okay, so the germ cell tumors, we have this germinoma, you have embryonal carcinoma, then you have choriocarcinoma, and then you have endodermal sinus tumor or yolk sac tumor. Sometimes you can find a tumor with all these mixed together. So a tumor has part of it showing this germinoma, part of it showing embryonal carcinoma, part of it has a yolk sac, other areas you're seeing chorio, and even some areas you're seeing teratoma. That's normally what you call a mixed germ cell tumor. But the takeaway message is that this occurs at an extremely early age. Young girl with malignant ovarian tumor, it is most likely a germ cell tumor among the ones we have listed here. Dysgerminoma, embryonal carcinoma, a yolk sac tumor, a choriocarcinoma, or an immature teratoma. Teratoma, when they have mature tissue that looks like adult mature tissue, the term we use is mature teratoma. If they have embryonal tissue, the term we use is immature teratoma, and immature teratoma is malignant. When they are producing a highly specialized tissue, like the ovary, then we say these are specialized or a monodermal teratoma. These are germ cell tumors. You can have teratoma, benign tumor with the differentiation of all the 3 germ layers, so they'll have ectodermal tissue, endodermal tissue, and mesodermal tissue. They're usually cystic. Most of the time they'll have skin, and that's why sometimes they are referred to as a dermoid cyst. They can have sebaceous material, they can have hair, they can have teeth, can have bone. If you see immature tissue, then that is a malignant variant of teratoma. Yes, like from here you can see teeth, you can even see hair. Even from this one, you see hair. This is sebaceous tissue. This is a mature, and it has cysts. This is a mature cystic teratoma. Okay, and you look under the histology. Just take it from me. Yes, this is cartilage. This is a hair follicle. This is a thyroid tissue. So not thyroid tissue. This is yes, this is a glandular tissue. You are seeing multiple tissues inside this lesion. There's another one, and you can even see what looks like a foot. So you have these stories of women saying, I went to the hospital, then I've been having pain for a very long time, and then the doctors removed something that looks like a fetus from my ovary. It had tooth, it had almost like skin. This is a fetus-like structure. You are most likely dealing with a mature teratoma. Okay. Now this is forming thyroid. This is forming thyroid. Even if you look closely, this does look like thyroid, and even from histology, we can confirm this is thyroid. This is what we call struma ovarii. This is a monodermal teratoma. It is forming tissue from only one cell line, but that tissue is not supposed to be in the ovary. Okay? This is immature teratoma in that the structures that are here are not adult tissue. They are fetal tissue. Okay? And this one is now malignant. Okay? Fetal tissue. So that is a ovarian germ cell tumor. The next one is ovarian sex called stromal neoplasm. These ones are arising from the stromal tumors, the stroma of the ovary. They arise from the dwelling cell that typically give rise to specialized gonadal stroma. Okay? And this includes the granulosa cell, if you have the thicker cell, Sertoli cell, Leydig cells, and the fibroblasts. The malignant ones are not common. So malignant ovarian sex called stromal tumors are not common. They are very few. Okay? Very few of them are malignant. And the one that are mostly common, these are granulosa cell tumors. And even for the malignant one, they tend to be low grade in that they don't give patient much problem. They tend to be mainly benign. The only problem with this ovarian sex called stromal tumors is that they tend to produce hormone. So they can produce excess estrogen. They can also produce excess androgen. So if you have a patient who has an ovarian mass and they have symptoms of androgen excess or estrogen excess, then you start thinking of the PCOS and also think of ovarian sex called stromal neoplasm, either granulosa cell tumor or a Sertoli cell tumor. These are the sex called stromal tumor. You can have a thecoma fibroma, yes, the fibrous lesion, the fibrous. This is coming from the fibrous and also of the thicker cells. You can have a granulosa thicker cell tumor or just granulosa cell tumor. This is coming from the granulosa cell. Then you can have Sertoli Leydig cell tumors. They normally can produce, granulosa cell tumors normally produce estrogen. So they are feminizing. So a patient will present with excess features of excess androgen, like menorrhagia. They'll have excess bleeding because of the endometrial hyperplasia. Okay? Now, Sertoli Leydig cells, but they normally produce androgen. So a patient will come with features of masculinization. It's a lady with features of masculinization. Basically, masculinization features here are things like hair loss, things like acne, things like obesity, and also features like oligomenorrhea or just amenorrhea. That is a masculinization. Okay. Then you can have others like gonadoblastoma, when you have a malignant tumor with a mix of germ cell tumor and also stromal tumor. That will be gonadoblastoma. We've talked about tumors metastatic to the ovary. These ones are from either from the GIT or from the genitourinary tract. Okay. So the only thing I want you to remember about the sex called stromal tumor is their issue of producing excess androgen for Sertoli Leydig cell and excess estrogen for granulosa thicker cell tumors. But these are sex called stromal tumors. Okay. This is a granulosa cell tumor. It has normally something we call Carl-Exner bodies. This is a granulosa cell tumor. You can see it's a solid mass, but the capsule here is intact. Okay. This is a Sertoli Leydig cell tumor, tends to be very yellowish and has large cells that are luteinized, meaning they have excess lipids. Okay, this is a fibroma. Yes, whitish, solid, benign. And when you look under the histology, you see spindle cells in a collagenous background. Oh, Kivali is asking, why do women with endometriosis have very painful periods? I've heard that it causes organ collapse, and how is the management therapy to avoid that? And what's the indication for surgical procedures for women with endometriosis? That's a very good question, Kivali. They'll have painful periods because these endometrial-like tissue that are outside the outside the endometrium they are functional, meaning they'll respond to the LH and the FSH. So, for instance, the worst form I've seen for endometriosis was endometriosis in the pleura. So, Kivali, picture that. You have endometrial tissue in the pleura. Sometimes we get them in the diaphragm. So during the normal cycle, these endometrial tissues, they also change. They also become menstrual. They shed off, they become hemorrhagic, and they're shedding off in an abnormal location. So in that location, they are taken as abnormal. And what happens that the body response in that location will be an inflammatory response. So they'll be, because at that location they are foreign. Yes, you are having endometrial tissue in the diaphragm. In the diaphragm, once you have that during the menstrual cycle, during the shedding off, during the apoptosis, there's a reaction, and the body response is an inflammatory response. So they are seen as some form of inflammation occurs, and inflammation tends to be typically associated with a lot of pain. So wherever they are, they will instigate some kind of a painful inflammatory response. So the indication will be how painful are they, and are they surgically amenable? Can you cut them off? And how many are they? If there are too many, they are all over the place. Yeah, they are in the peritoneum, they are in the ovary. If it's like in the ovary and it's giving you like in the metrotic cyst, like the one you had seen, then we can do the surgery. And surgery can be done either open or laparoscopy. Laparoscopy is better. I hope you know what you mean by laparoscopic surgery. But laparoscopic surgery, you don't make a cut. You just use spots, make some holes, and then they do the surgery without making a large incision. And for diagnosis and management, we prefer laparoscopic surgery. And then during that surgery, you hunt for all those they're normally seen as red patches like in the peritoneum. So you hunt for them and cut them out. If there are so many, what you do, you give what is called goserelin. Goserelin is a gonadotropin releasing hormone analog. It's called goserelin. You give a drug to cheat the body that there's excess gonadotropin releasing hormone. And when you have an excess of gonadotropin releasing hormone, the body stops responding to the normal gonadotropin releasing hormone. And when that occurs, it's like you stop menstruation. If you stop menstruation, then you stop the monthly cycle of bleeding in the endometriotic tissue. And if you stop that, then the pain reduces. That could be a way of managing. But typically, management is surgery. If you can, if they are few, if they are localized, if they're causing a mass problem, because sometimes they can cause a mass lesion. Okay, but it's easier to manage them with the gonadotropin releasing hormone analogs. Yes. Endometriosis, Rift Valley is extremely common. It's a very common lesion. So if you remember it, I'll be happy. Okay. Now this is a fibroma. This is what's called this is a dysgerminoma. When you reach when you are being told testes, remember the histology is almost the same like this. These are dysgerminoma. A solid mass can be very large, can be extremely destructive. My last patient was a 12-year-old, no, 16-year-old girl who had an extensive dysgerminoma. They had to remove almost all the pelvic organs. We are talking about a 16-year-old girl. And what the take-home message here is that if you see a young patient with an endometrial with an ovarian mass, think of germ cell tumors, mainly germ cell tumors. Okay? Now, let's wrap up the issue of ovarian carcinomas and put them together. We have already seen that the most common ovarian carcinoma is serous carcinoma. So we'll be referring to it mainly when we talk about ovarian carcinomas. Okay, 23,000 new cases, 15,000 deaths. This is the year 2007. These are American figures. The fifth commonest, the fifth most deadly cancer in women. Again, these are American figures. And the problem again with ovarian carcinoma, that's why they kill almost all the patients we see. I'm saying almost all, because they are normally not discovered early. I'll also tell you why they're not discovered early. The signs are normally not very specific. There's no specific sign that this patient has ovarian carcinoma. By the time you're seeing it, that, hey, this patient ovarian carcinoma is really advanced. Peak age normally is around 50 years. Most of them are serous tumors. Okay? Tumors are most likely benign in women less than 45 years of age. After that, they tend to be more malignant. Risk increases with age. Median age of presentation is 61 years of age. Peak up to 70. Approximately 70 will present with advanced disease. Advanced disease. If you have done Joy Nyawira, you have done cervical cancers. You've had a lesson on cervical cancer? But I ask Faith. Faith, you ever had a lesson on cervical cancer? And
not
you can
yet.
speak. Not yet. Oh, okay. Now let me explain. In cervical cancers, the main risk factor is HPV. HPV is sexually transmitted. And the more sex you have, the early sex you have, the more children you get, because if you have more sex, you get more children. Yes? So multiparity and more sex is normally a risk factor for cervical carcinoma. It is the opposite for ovarian carcinoma. Ovarian carcinoma, nulliparity, or having very few children, is more of a risk factor because of increased number of ovulatory cycle. And because part of it, there's the issue of being exposed to estrogen. Okay? So nulliparity is a risk factor for ovarian carcinomas, especially the surface-derived ovarian tumors. Genetic factors matter, especially BRCA1 and BRCA2 suppressor genes. Also, failure of DNA repair genes, the Leach syndrome. We see this in colonic cancers. Turner syndrome for dysgerminoma, Pearce-Jaeger syndrome for sex-cold tumors. So these are a genetic factor like a familial, but BRCA1 and BRCA2 mutations are the most common. Okay. Other risk, increased risk in postmenopausal women who are given hormone replacement therapy, especially estrogen. Increased risk in obese, again, excess estrogen exposure. OCPs and pregnancy normally decrease risk factor for surface-derived ovarian cancer. So combined oral contraceptive pill, because you are reducing the exposure to estrogen. In combined contraceptive pills, we normally give both progesterone and estrogen. And when you have more pregnancy, when you're pregnant, in pregnancy the predominant hormone is progesterone, not estrogen. So the more pregnancy you have, the less exposure you have to estrogen. Okay, so those are risk factors. Symptoms: feelings of fullness or bloating, you have a pelvic pain, you have back pain, you have normal menses. They are very non-specific clinical features. So we are not going to use one of them to say this patient has ovarian carcinoma based on fullness or bloating. It could just be gas. And that's normally the fallacy, that you ignore this kind of signs. Then by the time now it's being discovered, it's very late. The treatment, surgery just for debulking, you can give radiation, you can give chemotherapy. And they use a tumor marker called CA125 as to monitor treatment. So once you've done the surgery, you check before you do the surgery, then you check after the surgery, after the treatment, to see whether there's a response. We don't use CA125 for diagnosis. The prognosis depends on stage. Cancer confined to the ovary, that is stage 1, 5-year survival rate of 70%. Cancer through the ovarian capsule, that is typically stage 1B, 1B2, survival rate of 13%. We rarely get them at this age. We most likely get them at stage 3C when this patient now have mets to the peritoneum. Okay? Most present with high stage disease. And this is the primary reason why relatively poor 5 to 10 year survival rate for these carcinomas. They might not be as common as breast, but they uniformly kill. Okay? CA125 is used in patients with non-disease to monitor disease recurrence or progression. It's not used for diagnosis, because CA125 can be present in other lesions. Okay? You can screen to identify women at risk using a BRCA2 mutation, or if they have a strong family history. And when you confirm that they have a BRCA2 mutation, they have a strong family history, normally what we do is you can do salpingo-oophorectomy. This is called prophylactic or risk-reducing salpingo-oophorectomy. You remove the ovaries early before the cancer appears. Because if you have BRCA1 mutation or BRCA2 mutation, chances that you'll get cancer, this ovarian carcinoma, is very high. You're talking of 70 to 80% by age 65. Okay. BRCA1 and 2 testing is very difficult. It's not a very easy thing, and it's very expensive. It's almost, I think currently is $3,000. There's something you do when you have a very sure that there's a very strong family history. I'll explain it better again when you come to breast carcinomas. This is a summary of the ovarian tumors, as surface epithelial cell tumors, germ cell tumors, sex chromosomal tumors, and then metastasis to the ovary. And you said 60 to 75% of all the malignant tumors are surface epithelial. So when you're talking about ovarian carcinoma, you're most likely talking about surface epithelial tumor, especially serous carcinoma. Allow me to move to the breast. Breast, I'll be fast. I'll show you the images of other lesions, and I'll concentrate only with the breast carcinoma.
Excuse me, Doc.
Yes.
Before you move to the breast, do we have any relationship of fibroids to either follicular cysts or ovarian cancers?
No.
Okay.
No. Fibroids tend to be, in fact, their malignant potential is very low. They are caused by a completely different pathway.
Thank you.
Okay. Disorder of the breast, it can be congenital, it could be inflammatory, it could be neoplastic. A neoplastic is benign, that's malignant, and you're done. So for you, the only thing that you need to remember very well is how do breast lesions present clinically? What do you look for? How do you make the screening? When you talk about breast self-exam, what are you going to tell your patient to actually be doing? Okay. Anatomy and development, I'll show you the photos. Congenital, I'll show you the photos. Inflammatory, there are only two that are predominant. The rest are neither here nor there. Neoplastic can be benign, I'll show you the predominant one. Proliferative with or without atypia, this is a very difficult ground. Okay? I wouldn't want to expose BFAM students to that. I'll talk about benign, one lesion, and then I go straight to carcinoma. I'm also going to avoid the in situ carcinomas. I'm only going to talk about the invasive carcinomas. Okay? And remember, we are talking about two types of breast. Okay? Two types of breast. There's the male breast, not a very interesting breast. We'll mention it at the end. So the breast we are referring to, yes, the female breast. This is the developmental stage from stage 1, Tana 1 to Tana what we call Tana 4. So patient might present with early development, or patient with development present with no development, or they can present with very mild development. So from early development to no development, so hypoplasia, aplasia, or many of them are just smaller. But this is the way they are supposed to develop from Tana 1 to Tana 5 staging. Okay. This is the normal breast. Again, this is female breast. Okay. This is the nipple, and the nipple normally is drained by large ducts we call lactiferous ducts. Breast has veins, breast has arteries, breast has lymphatics. Yes, breast normally is made of two main types of tissue. We have the stroma, and the stroma tends to be mainly fat, and then we have the glands. So in a young breast, the glands are more than the adipose, and that's what makes the young breast to be firm. As you grow older, as you lose the estrogen, the glands become smaller, the adipose increases. Okay, this is the pectoralis muscle. This is the chest. This is the chest wall. So this is the pectoralis muscle here. This is the intercostals, and these are the ribs. Okay, and this is the ligament that limits the breast to the chest wall, the so-called Cowper's ligament. Okay, that's a lobe. When you're talking about a breast lobe, that's a lobe supplied by one large duct. This is a lobule. This is now the athena cells forming a one lobule. This is a lobe. This is a lobule. Okay, and this is a duct. So when you come to the breast, we'll have two forms of breast. Two, there are many. For you, remember two. We have ductal and lobular. So you have invasive ductal carcinoma, we have invasive lobular carcinoma. The rest are not for you. There are more than another 100 plus. Okay? This is the athena. This is where the milk is made. This is the athena. So you remember the division, the major divisions here. We have a lobe, and then we have a lobule, part of the lobe, and then we have an athena. The single gland is called an athena. This one you have here normally has two layers. This layer is called the myoepithelial layer. This is the epithelial layer that makes the milk. Okay. Again, the same thing. You have fat, then you have the lymphatics, you have the milk duct, you have the glandular tissue, then you have the corpus ligament over there. Okay. The lymphatic drainage is very important because that's how we define the cancer staging and where. So if the cancer, this is the internal mammary gland, lymph nodes. This is the supraclavicular lymph nodes. These are the axillary lymph nodes. When you're palpating for lymph nodes around here. You're palpating for lymph nodes around there. When it reaches this stage, this is a very advanced stage. Lymphatic drainage, very, very important. Okay. The skin and the most of the breast tissue will drain to the axillary lymph nodes. Okay. Some of them will go to the internal mammary lymph nodes. Others will go to supraclavicular. Others will go to intercostals. Okay. And breast normally is formed through what we call the milk line. If you have seen, I think the best is a dog. A dog normally has multiple breasts, but along a single line. This normally was called a milk line. So the predominant one is here. And the breast is a skin adnexal structure. It's actually formed from the skin. And it's formed along this line. So if breast is not along this line, it's in abnormal location. If it is lower than here, then but it can be any along this line. And you can even find breast tissue in the vulva. We have fibrinomas appearing in the vulva, or a lesion that looks like fibrinoma in the vulva. But this is the milk line. Okay. This sort of development, either one side is formed. You can see a small one on that side. This side is not formed. Here, nothing. A small one is formed there. This patient has none completely. Typically, this is what a patient might be having, Turner syndrome. This one is larger than the rest. This is a bit small. This is larger. These are developmental abnormalities. You can reassure your patient, or you can confirm why are they having this lack of development. You can have multiple nipples. Multiple nipples, we call it polythelia. So you can have another nipple there, you can have another nipple there along the milk line. Okay. Like this one here is, the nipple is there, there's another one here. Yes, there's another one there. There are two of them here. There's another one there. They can even be on the foot. Okay, this is polythelia, multiple nipples. You can have an accessory breast tissue. You can have breast tissue in the axilla, very common. You can even have cancers arising here. And you've seen patients where the other side of the breast is normal, but the cancer is starting from the accessory breast tissue in the axilla. These are just variations. You can have nipple retraction, which is congenital, or it could be acquired from a carcinoma, can give you nipple retraction, or it could be acquired from a nipple piercing. So when a patient has nipple retraction, you have to confirm, because nipple retraction is a very common feature of advanced carcinoma. You can have extremely large breast, excessively large, especially in around the puberty. And when the weight of the breast is more than 3% of the total body weight, or is more than 1,500 grams, then we call that one macromastia. Or the other term normally used is gigantomastia. Gigantomastia is very common. This one needs to be, this is where what you do is called reduction mastoplasty. You reduce the sizes. Like this one has been reduced. You see, this was the initial, this after surgery. And this one can occur even during puberty due to excess or increased sensitivity of breast tissue to the female hormone. This is macromastia or gigantomastia. The same thing, but sometimes you get this where the tissue is there's also not just the breast element being bigger the glandular element, but also the stroma, so that the breast is hard and is very large. This is called hypertrophy. Again, it's occurring in young girls. Excessive or increased sensitivity of breast tissue to pubertal hormones. This is gigantomastia. It could be part of the obesity, or it could just be an abnormal development of the. And this can give you a lot of problem, especially backache. Yes. No. So for congenital manifestation, you can have either multiple nipples or nipples, abnormal location, ectopic location of the nipples, or ectopic location of the breast tissue, or a very small breast that has not very developed, or there's completely no breast development, or there's excessive breast development like the macromastia. Now, before we go to the breast lesions themselves, how do breast diseases present? Okay, they present mostly as a lump, mainly as a lump, but they can also present as pain, what we call mastalgia or mastodynia. They can present as nipple discharge, or they could only be discovered during a screening by mammography. During mammography is when they are detected. And most of the lumps represent benign things. So if you see a breast lump, try to reassure your patient it's most likely benign, but they need to be evaluated. They can be evaluated by ultrasound, by mammography, by fine needle aspiration, and by biopsy. So the typical presentation of a breast disease is a breast lump. You can have pain, you can have nipple discharge, you can have what we call mammographic signs, the densities and calcification on mammography. Now, once you see that, you evaluate them with ultrasound, mammography, fine needle aspiration, and biopsy. I'll come back to this. Okay. So, symptoms for patient. Inflammation, you can have a palpable mass, you can have lumpiness or other symptoms, you can have pain, you can have nipple discharge. Okay. And when you have nipple discharge, 7% of them will be cancers. A palpable mass, 5% of them will be cancers. 11%, 1% lumpiness or other just non-specific symptoms. You can also have abnormal mammogram. You can have a palpable mass. You can have inflammatory changes. You can have nipple discharge, and you can have pain. So this is the symptom of the patient. This is the presentation of the patient. So clinical signs, and then the clinical history. Okay. Most breast lumps are benign. A very high percentage are from fibrocystic change. Other miscellaneous benign. Fibrinoma is very common. 10% of them will be cancer. You might end up with a lump, but not giving you a definite disease in 30% of the lesions. Okay. So based on histology, you can be able to tell where this lesion is arising from. So you can have a variety of breast lesions, either arising from the ducts or lactiferous sinuses. You can have intralobular stroma, giving you a lipoma, fibrous tumor, fibromatosis, or even sarcoma. You can have lobular stroma, giving you fibrinoma or phyllodes tumor. You can have a terminal duct, giving you the cysts, the adenosis, the papilloma, the hyperplasia, and then the carcinoma. So carcinoma, you can see, is coming from the duct. It's also coming from, typically from the ducts and the lobular unit. So you'll have ductal carcinomas and lobular carcinoma. This is what we are trying to show. Remember, breast has trauma, so breast can also have soft tissue malignancies. The hemangiomas, the angiosarcomas can also arise from there. The invasive carcinomas do arise from the ducts and from the lobules. Fibrinoma arises from the lobules. The glands can have epithelial hyperplasia. Okay, you can have a papilloma inside the nipple, and this will give you nipple discharge. There's a simpler way of showing it. Stroma can give you fibrinoma or phyllodes tumor. A lobule can give you a lobular carcinoma. Terminal ducts will give you tubular carcinoma. A major duct can give you fibrocystic change and ductal cancer. Lactiferous duct can give you intraductal papilloma, can give you an abscess, can give you other inflammatory breast lesion. Nipple can have Paget's disease and a breast abscess. We'll mention this in passing. Okay, so what about the inflammatory breast disease? We say there are mainly just two. There's the acute mastitis. This one you get infection when a lady is breastfeeding. During breastfeeding, okay, due to bites and nipple cracks when during lactation. And this one normally resolved with antibiotic. You don't stop breastfeeding because of that. But the problem is if this is not treated, you might end up with an abscess. It's acute mastitis occurring during lactation due to either staph or streptococci, due to nipple cracks and fissures. Okay? So you just rest the breast, give antibiotic, give some warm compression, and you still allow breastfeeding. Okay? This is the mastitis. There's some inflammation here. This now has become an abscess. This now is an abscess. And when you see this is lanced, you can see pus coming out. Now this is an abscess. An abscess now, you stop breastfeeding. You make sure this is drained very well. But when you stop breastfeeding, means you have to continue expressing the milk. Because if you don't do that, you'll end up with other problems, like breast engorgement. It can ulcerate and give you more serious problems. So this has to be dealt with very fast. This is an ulcerated, an abscess that got ulcerated and became septic. Okay, you can have granulomatous mastitis. It's a mastitis with granulomas, either from infection like sarcoidosis, no, from infection like mycobacterium fungi, foreign bodies like piercing, and other systemic diseases like sarcoidosis. Basically, it's inflammation, but it has granuloma. This is big granulomatous mastitis. In our setting, you should mainly worry about mycobacterium or tuberculosis. Okay. Now, we go to the epithelial lesions. Epithelial lesions can be benign, can be malignant. When they're malignant, they're carcinomas. The benign epithelial lesion can be non-proliferative, can be proliferative disease with atypia, can be proliferative disease with atypia. But they are epithelial disorders. The problem now is in the epithelium, not the stroma. Okay, non-proliferative and proliferative change, and this just because of the excessive exaggeration of normal breast cycle. This anomaly tends to be more hormonal. Yeah? So what we call disorders of normal development and involution. So these are patients who typically they'll tell you they feel breast pain during menstruation. If you see that, then you're most likely dealing with the fibrocystic change. And fibrocystic change is very, very common. And you can see we are calling it fibrocystic change and not fibrocystic disease. It's rarely associated with increased cancer risk unless it is proliferative. Okay. Non-proliferative fibrocystic change increases stroma, the dilatation of the ducts, and formation of cysts. Proliferative disease, the fibrocystic remains now. There is hyperplasia of the breast epithelium. I'll show you this. And if the epithelium shows atypia, now you have increased cancer risk. So the benign, for the breast, benign epithelial disorder, remember we said non-proliferative, proliferative with atypia, and proliferative without atypia. When there's atypia, now these are pre-malignant breast lesions. When there's atypia, I'll show you what you mean by atypia. This is breast, and even from this point, you can see small cysts. You can see small cysts. This is a fibrous area. This is a fibrous area. So it is fibrous and it is cystic. So it is a fibrocystic change. And you look under the microscope. This is a normal breast. You see this is a normal breast. This is a duct. This is a lobule. This is an acina. So for the fibrocystic change is a bit different. You can see now there's a large cyst here. and the lobules look scattered, and there's a fibrosis in this, and then there's a chronic inflammation. So fibrosis and a cyst giving you fibrocystic change. Okay. Now, they can have proliferation. This is the way a normal acina is supposed to be. You can see it only has two cell layers. This is layer 1, and this is layer 2. This is a normal acina. But you can see this acina is full of cells. So this is a proliferation, proliferative. This is a what you call hyperplasia. And on top of that, this is a mammography. This is a what you call a guiding wire. You can see a wire there, and even this one you can see some white areas in the mammogram. These are calcifications. That's what we mean by mammographic changes. And even from this point, again, you can confirm this as cyst. And when you look under the microscope, you see a larger dilated duct. This is a much, much larger duct. You can see these things in the middle there. Those are calcification. And even the cells look different. They look more reddish than what you see here. This is normally what we call oncocytic metaplasia. When you're reading books, you'll see those terms. So this now is a fibrocystic change, but with a proliferation. With proliferation. Still benign. But the moment you start seeing proliferation, meaning this could change to becoming cancerous. This is proliferative breast lesion. And instead of having only two layers, now the cell is the cells are filling up the acina. This is a proliferative fibrocystic change or proliferative breast lesion, but there's no atypia. Okay, and this table is there to show you that if you have a proliferative breast disease without atypia, then there's a slightly increased risk of carcinoma. Non-proliferative breast disease, the risk is very low. As the proliferation increases, the risk increases. As the atypia increases, the risk increases. I don't want to bore you down with these particular details. Just remember there's non-proliferative breast disease, there's proliferative disease without atypia, there's proliferative disease with atypia. When there's atypia now, like a typical ductal hyperplasia, a typical lobular hyperplasia, now the risk increases. A carcinoma in situ means it's a carcinoma that does not invade the stroma. Then the risk now is much, much, much higher. So the list of the epithelial breast lesion and the risk of developing invasive carcinoma. And that's the reason when we are reporting this now for the clinicians, we have to indicate for them where is there proliferation. Is there proliferation but with no atypia? Is there proliferation with atypia? Is this carcinoma in situ? So the patient now can be managed based on this profile. I'm mentioning this before we go to the carcinoma because this is also very common. If I find a breast mass, a well-defined breast mass, in somebody we are talking from age 13 to age 25, then you're most likely dealing with a fibrinoma. Again, a very common disorder. The most common benign breast tumor is normally stimulated by estrogen because that's the time where you have those estrogen changes. Peak incidence around 20 years. Normally, it's a solitary, discrete, movable mass. It's called fibrinoma because there is the fibrous part and then there's the epithelial part. But they are all benign. You can see this is the breast, this is the fat, but there's a well-demarcated mass here. There. Okay, we'll see how cancer is a bit different. This is a well-demarcated mass. This is most likely fibrinoma. Under the microscope, again, you can see the boundary very well there. You can see the epithelium that is proliferating, and then you can see the stroma. And that's why it's called fibro. Fibro refers to this part. Adeno refers to the glands. Very common, very, very common in our setting and at that age group. My rule of thumb rule. My thumb rule normally is that if a lady is more than 24 years and they have a breast mass we'll assume that is cancer in our setting until we prove otherwise. From around 24 to earlier than that, then it's most likely one of these, most likely a fibroadenoma. It could most likely be benign. Okay. Let's go to the main topic. And again, for the main topic, I'm not going to bore you down with the details of each histological subtype. I'm going to go to my main talk will be on what do we do now with the patient. Now we have breast carcinoma. How do we move from there? Okay. 180,000 new cases, 40,000 deaths in 2007. Again, these are USA figures. The most common, the second deadliest cancer in women. A lifetime risk is 1 in 8. 75% of patients are over 50 years. These are American figures. I'll give you ours. Ours is worse and much, much different from this. Okay. The rate was increased by now stable, not really. These are American figures. Our rate, I think it has changed. It has not really changed. No, it's just getting worse. Okay. I'll give you what we have. Yes. Remember I told you at the beginning that I don't want you to go into the details. I want you to remember how do we manage your patient. And the management depends on the histology, also depends on what we call breast cancer biomarkers. And the biomarkers, normally what we do is ER, estrogen receptor, we do what is called progesterone receptor, we do what is called a Ki67, this is normally what we call a proliferation index, and then we do something called HER2, human epidermal receptor 2. So we combine histology with this, and then we know how to manage the patient. And then also based on the prognostic features that I'm going to show you. And that will determine how you manage your patient. The Europeans have what is called luminol A. Luminol A is the one that occurs in, I'll show you what to mean by luminol A. But before we reach there, luminol A breast carcinoma, these are carcinomas that occur in older age group. This is postmenopausal breast cancer, typically postmenopausal. And the good thing with them, they tend to be low grade, they don't grow very fast, and they are normally estrogen receptor positive. If it is estrogen receptor positive, so you give a drug to modify or to block estrogen receptor. And that's where now tamoxifen comes in. Yes? Now, the HER2 disease means it's HER2 enriched. It's being caused by an abnormality in the HER2. These ones do respond to what is called Herceptin or imatinib. I'm coming to that. Now, the triple negative means all the biomarkers are negative. So ER negative, PR negative, HER2 negative. Yes, so they don't respond to the estrogen receptor agonist or selective. You normally call them estrogen receptor selective modulators or estrogen receptor modulators. And the best example here is normally a drug called tamoxifen. So they'll not respond to tamoxifen. So you can't give them tamoxifen because they are estrogen receptor negative. They also tend to be HER2 receptor negative, so they'll not respond to Herceptin, so you can't use Herceptin. Their tumors tend to be very aggressive and then they grow very fast. Okay? So basically means for this triple negative breast carcinoma, you are limited to chemotherapy and radiotherapy. And those are actually not a very good way of managing cancer. They have a lot of side effects. I'm coming to that. And that's the reason I'm trying to avoid the finer details of the histology. Okay. This is a question you normally ask because you have to know the breast carcinoma risk factors. The age, the family history, increases of the exposure, obesity, alcohol consumption, and high-fat diet. That if you break it down, this table shows them better. A female gender is a risk factor already. Female gender, just being female is a risk factor already. The relative risk factor of 4, actually times 4. Increasing age, of course, yes, cancer occurs at a slightly higher age group. The more you age, the more the risk increases. If you have a germline mutation of high penetrance, germline mutation of high penetrance like BRCA1 mutations, if a strong family history, first degree relative, like the mother had breast cancer, maternal aunt had breast cancer, grandmother had breast cancer, and this cancer had appeared at a young age, and this patient had also multiple cancers, like for instance, they had ovarian carcinoma. This is what we call a strong family history. Again, this tends to be mainly BRCA1 mutation cancers. If a patient has a personal history of breast cancer, they had a previous breast cancer, then the risk factor increases. They have a high breast density, means they have more glandular tissue. This needs to be investigated. Okay? I don't have the data, so I'm speculating here. But this could be a reason why we have a lot of breast cancer in our young women. Okay? I'll come back to that. Then you have mutations that have low moderate penetrance, means you have a mutation, but the physical characteristic of the disease might not be appearing. Radiation. A family history like one first degree relative, not multiple first degree relative. Like maybe just the mother or the maternal aunt or the maternal grandmother. Here you have more than one first degree. Mother, maternal aunt, even uncles, yes, or even a grandmother. Okay. Early menarche. Menarche starting much earlier, late menopause. Yes, late first pregnancy, nulliparity, absence of breastfeeding, exogenous hormone therapy, postmenopausal obesity, all these are related to increased estrogen exposure. All those factors are because of increased estrogen exposure. And you can tell. You are starting menarche early, meaning your estrogen levels are occurring much earlier. So by the time you are reaching 40, you've been exposed to estrogen for more than 28 years. Compared to somebody who starts menarche at 16 years, it meaning the estrogen exposure is low. And breast cancer is, we'll see a pathway where estrogen exposure actually is it's one of the pathways. Absence of breastfeeding. If you're not breastfeeding, you'll have estrogen throughout. If you're breastfeeding, you change. If you're pregnant, you change to progesterone. You stop having estrogen. Physical inactivity and high alcohol consumption. Yes, we think, again, this could be the problem also you're having here. This one I have seen in real life. Obesity and breast cancer. Of course, obesity has other issues. But this is a very good summary of the risk factors for developing breast cancer and summarizing what we have here. Okay. 50%, 5 to 10% of the cases are hereditary, and most of them, what if the first degree relative has a breast cancer? Most of them are BRCA1 or BRCA2 mutations. These are tumor suppressor gene with also DNA repair capabilities. We said genetic testing can be difficult. We need a highly specialized lab test, and you're saying most carriers will get cancer by age 70. Yes, by age 70. I'm bringing up this again just to confirm for you, because when the politicians and everybody in our country is talking about breast cancer, sometimes they gloss over issues. The breast cancer that we have here is slightly different from what I would say the Wazungus have, because our predominant one, and especially in women who are premenopausal. Premenopausal means they are less than 55. Most of them are 34, 32, 48, 45 there. Most of them will be here. Majority of these breast cancers are triple negative, meaning they are ER negative, PR negative, HER2 negative, and they are actually very high grade. And this tends to be from a BRCA1 mutation, and it's the same BRCA1 mutation we saw with the ovarian cancer. The same BRCA2 mutation we saw with the ovarian cancer. Okay. There are other mutations like P53, like the Peutz-Jeghers, like the cadherin defects, the one that you see in gastric carcinoma. There are others. I'm bringing up this because, again, to actually just now give you the part of the familial history. Don't worry, I'm almost finishing. Who knows this lady and why we are showing her here? Anybody who can combine why we are showing this lady and the two topics we have discussed? Nobody remembers this lady, or people are too young to remember this lady. It will actually bring out the point that we are trying to make. And it will show how the management outside there has changed. And maybe we should also be that aggressive. Yes, Timothy says this is Angelina Jolie. Yes, and I think, yes, Faith and Mutua has nailed it. Yes. Angelina Jolie discovered her mother died of breast cancer, her maternal aunt died of breast cancer. Her grandmother also had the same problem, so she went for testing. She was found to be BRCA1 positive. She decided to go for what Faith has told you there: double mastectomy plus bilateral salpingo-oophorectomy. Because Faith, remember, the same BRCA1 is what you are going to see in the serous carcinoma of the ovary. Yes, serous carcinoma of the ovary. It's the same. So this is what she said. And when this came out, there was a lot of interest in BRCA1 testing. BRCA1 testing is difficult. It's not easy, and you have to do a lot of calculation. Because if I find it, doesn't actually mean that you will get the cancer. But if I find it with the relations from your previous family history, then you can calculate that if Angelina Jolie would have not done what she did, there are chances that by the time she reached 75 years, she would have developed either breast carcinoma or ovarian carcinoma or even both. Okay? Again, remember I told you I'm trying to avoid to give you the finer details of the histology so that you understand how we manage breast cancer. And the management of breast cancer is depending on this, how they develop. There are three pathways. There's a pathway where you have BRCA2 mutation, giving you abnormal an oncogene, and this abnormal oncogene will lead to an invasive carcinoma that is ER positive and HER2 negative. ER positive, HER2 negative. And most of the time, the proliferation index here will be very low. That's normally what we call luminal type breast carcinoma. So luminal type breast carcinoma, ER positive, HER2 negative, Ki67, this the proliferation is low. This one will respond to treatment, including surgery. They grow very slowly. They respond to tamoxifen, that's the estrogen modulator, and they also respond better to chemotherapy. They don't do very well with radiotherapy. Okay? Then you have the the other pathline where you are using a P53 mutation abnormality. There's a bit of HER2 amplification. HER2 is a human epidermal receptor 2. And this amplification gives you a HER2 positive cancer. So normally this one, ER is positive, PR is positive, HER2 is positive. So these patients, the problem is that they might be either low grade or high grade, but if they are not given a drug to block the HER2, they normally have a much higher chances of developing recurrence if you don't give them imatinib. Imatinib or Herceptin is extremely expensive. But if you don't give them and they are HER2 positive, the recurrence rate and even metastatic potential is much higher. Then you have the worst form, typically from BRCA1 mutation. This is actually the typical familial cancer. P53 mutation, of course, is there. You have BRCA1 inactivation. You form ductal carcinoma in situ. Then the cancer you end up with is called triple negative. Triple negative means ER is negative, PR is negative, and HER2 is negative. And this tends to be extremely aggressive carcinomas. They don't respond very well to, they will not respond to Herceptin. They'll not respond to tamoxifen. So you are left with chemotherapy and radiotherapy. And as I said, they're actually the most aggressive of the breast carcinomas. Unfortunately, they are the type of cancer you find in African women. Unfortunately. Yes, unfortunately. They normally have a very high proliferation, ER negative, PR negative, HER2 negative, high proliferation. So you do their DNA level, they have very high proliferation. mRNA level, you see proliferation genes are much higher, HER2 genes are not there, ER genes are not there. And when you do histology, the ER positive tends to be low grade, triple negative tends to be extremely aggressive. Yes, so luminal A, ER positive, HER2 negative, we call it luminal A. Okay, they are normally very low grade. They are the tubular carcinomas, the lobular carcinomas, the mucinous carcinomas, the papillary carcinomas, and they find this in older women, and then men. This is normally detected by mammographic screening. Their response to chemotherapy is not very good. Sorry. So this one's surgery is better. This group surgery is better. They normally metastases, they go mainly to the bones and the viscera. They have a low rate of relapse. Their recurrence rate is very low. And they have a long survival. Long survival. Yes. So this is what is in the European women and postmenopausal. Okay. Then you have the HER2 positive. This means 20% of the breast cancers have HER2 positive. They are HER2 enriched. Okay. The mutations you get there now are the oncogenes. Oncogenes and the tumor suppressor genes. Can have histology, can have some apocrine, some micropapillary. We see this again in young women. The ER normally is positive in some cases. Their response to chemotherapy is slightly better. The metastasis to the bone is much higher, and even to the brain is much higher. They present with the recurrence can be either early or late. So their prognosis is Not so good, but also not so bad. Now, the form that we have in our setting in a young, you can see young women, women of the African heritage. Of course, we are African, so this is us. They normally BRCA1 mutation carriers. Okay, the mutations now you get is mainly T53 mutations. They are the medullary features, they are metaplastic, they tend to be more aggressive, they tend to be more grade 3 tumors. Okay, they metastasize very early to the bone, and then they go to the brain also very fast. Their recurrence rate is very high. Very high. Yes, recurrence rate is high. Almost less than 8 years, even after treatment, there will be a recurrence. Most of the recurrence I see is in months. You do surgery, you do chemotherapy. 1 year later, the patient is back with the same disease in another location. Okay. Survival rate for these patients are low, and this is what we have mainly in our setting in premenopausal. I'm not saying we don't have this. For our postmenopausal women, it is there. But for our premenopausal women, the predominant one tends to be triple negative breast carcinomas. Okay. That is HER2. We have to test for HER2 before we give you the imatinib. Okay. For distant metastasis, triple negative has much higher levels of metastasis, followed by HER2. Okay. The luminal type, the good type, the one that you find in postmenopause, the rate of distant metastasis is much lower. You can see, so basically we are saying that by the time you're diagnosing the triple negative breast carcinoma, there are very high chances that it has metastasized. It's a higher stage. By the time you're discovering this lesion, most likely it has gone far. And that's why we are saying we encourage mammography, that if discovered early, very few patients will have axillary nodes. And once you have axillary node metastasis, that's a bad stage. And when you have fixation to the chest wall, adherence to overlying skin, pudorine changes, that's a bad stage. Okay. You can see this a left breast screening. You don't have to see any mass. This is normal. This one now has a small mass. This is mammogram. This advanced breast disease. Yes, you can see the skin is reddish and eroded, and compared to what we have here. This is most likely a breast disease that has metastasized and is in the nodes. Yes. This is what we call pudo-orange. For the guys who did French, you can see this skin looks like the orange skin. If you see this in a lady, this is a really, really bad sign. You have a breast carcinoma here that has gone to the lymphatics, making the skin look like orange skin. This advanced breast carcinoma, this is normally what we call inflammatory carcinoma. It looks like mastitis, but it's actually not mastitis. Inflammatory breast carcinoma. Yes, again, inflammatory breast carcinoma. This is a normal breast. This is an advanced stage carcinoma. I'm showing you this because, yes, when you go to the village, if you see something like this, you have to be worried. Breast carcinoma is logical type. Sometimes you can have the one that has not invaded. If it is not invaded, we call it ductal carcinoma in situ. And if it's arising from the ductal carcinoma in situ. If arising from the lobules, lobular carcinoma in situ. When it invades, we call it ductal carcinoma or lobular carcinoma. Inflammatory carcinoma is when it invades the subcutaneous or the dermal lymphatics, giving you this skin thickening that looks like orange skin. They call it inflammatory carcinoma. This was the normal breast. This was lobules that are full of cells. This is breast cancer now after a surgery, you can see the fibrinoma was round and well demarcated. This one is infiltrating there, it's infiltrating there. It is very regular. Yes, it's very regular, and the margins are not very clear. You see this, then you're most likely dealing with an invasive carcinoma. Yes, this is histology. These are now the tubules. These are low grade. This one now you're not seeing tubules, you're just seeing cells. So these are just malignant cells. It doesn't even look like breast anymore. Some of the cells are extremely large. We can see mitosis. These are high grade carcinoma. Yes. And this is a skin. This is the epidermis. This is the dermis. And you can see cancer cells blocking the lymphatics. This was going to give you the orange skin changes. We normally grade carcinomas. And the grading from grade 1 to grade 2. I mean from grade 1 to grade 3. Grade 1 to grade 3. So well differentiated, moderately differentiated, poorly differentiated is based on the nuclear pleomorphism, the tubular formation, and the mitosis. I'm going to mention why I'm talking about the grade. Yes, this is carcinoma. This is a carcinoma. You can see now this is mammograph, and this is a mass that is very regular. It's very regular. Yes, and when you see it here, very regular mass infiltrating into the tissues. This is cancer now here. We are not even seeing any. We're not even seeing any tubules. All these are just carcinomas. Yes, this has a lot of mucin, so this is called mucinous carcinoma. This one has no shape at all. It's just cells and cells and cells. At least this one you can see tubules, but they are malignant tubules. Okay, this one you had mentioned. There's crusting. This is extremely inflammatory. So the first picture was showing you that was inflammatory breast carcinoma. Yes, this is just cells and cells and cells with nothing. It doesn't look like the breast anymore. Yes. It's just the grading part. Now, finally, we show you how do you give prognostic factors? How do you say this is a high-risk disease, this is an advanced disease? What are the criteria? What do you see? What are you supposed to use? The size of the tumor, that's what gives you the stage. Basically, the stage. The most important prognostic marker of breast carcinoma is the stage. And the stage is based on the size of the tumor, the lymph node involvement, and the metastasis. The grade of the tumor can also, a high-grade tumor has poor prognosis. There are some histological subtypes that are better prognosis. Okay? This is the table now to show you that for prognostic factors for invasive carcinoma, the stage matters. So the distant metastasis, the regional lymph node, and the tumor size. Yes? This is the most important prognostic factor, the stage. And the stage is based on distant metastasis, regional lymph node, and the tumor size. And of course, the tumor size, the T of the tumor, staging normally we use something called TNM, tumor node and metastasis. So the T of the breast is mentioned by the size and the involvement of the skin. If it is involving the skin, like inflammatory carcinoma, it's a bad prognostic sign. It's a high stage. Yes. So histological grade, higher grade means a bad prognostic sign. Now, the expression of ER and PR matters. Survival is highest for the most favorable combination of high ER, high PR, and absent HER2. And the least favorable for a combination of absent ER, PR, and HER2. This is the triple negative. So triple negative has a bad prognostic sign. Okay. Other prognostic signs, when you see lymphovascular invasion like this one, what I was trying to show you here, like this, It's a bad prognostic sign. Basically means this tumor is in the lymphatics. It can go to the nodes. Yes. Another prognostic sign, is histological subtypes. Some histological subtypes are better. So if you see tubular, you see adenocystic, they're usually better. If you see metaplastic, you see medullary, you see what's called micropapillary. So some histological subtypes are actually not very good. Response to chemotherapy is a very strong prognostic sign. So if you give a patient chemotherapy, normally you give chemotherapy before you test treatment, before you do surgery. It's normally called neoadjuvant therapy. So if I give neoadjuvant therapy, if I give chemotherapy or I give radiotherapy before I do the surgery, and then after we do the surgery, we confirm this has been response to chemotherapy, then that's a good sign. That's a good sign. Response to neoadjuvant therapy. Okay. Gene expression profiling, we do them when we have a tumor that we cannot, we want to identify patients who are not responding to estrogen therapy. ER is positive, but they are not responding to estrogen therapy. This is a more specialized, and that's why I told you, if the Americans are dying of breast cancer, then around here it could be worse, because we don't do this kind of thing. We don't profile our patient to that sensitivity level, so that we tailor even the treatment to that particular patient. But these are the prognostic factors for invasive breast carcinoma. And again, I'll repeat, stage is the most important. Don't worry about that part. This is how we do the staging. The staging is based on the T, the N, and the M. And you can see the 5-year survival rate based on that. So a very low stage 0, 92%. And that's why we are telling our mothers, our sisters, to actually go for this screening early. If it is found early, you can see a 5-year survival rate is much better. By the time you're getting a metastasis, the 5-year survival rate is dismal. Basically, when we say 13%, it means if you have 100 patients, only 13 would be present or would be there in 5 years. Now, for a pharmacist, we must give you the newer ways of managing our cancer patients. We must tell you that. Because you'll not be working just for county hospitals. You'll be working for big hospitals. You'll be working outside the country. We hope Trump will have now quietened down slightly, so you can even go to the US and practice in the US. So in the US, there are newer formulation. And even in our major hospital, like in Kenya, I've seen this with the Nairobi Hospital, I've seen this in Aga Khan, they give this kind of treatment. So if your patient is estrogen receptor positive, then we do what is called estrogen deprivation. We can do oophorectomy, or we give a aromatase inhibitor. Aromatase is the enzyme that converts androgens to estrogen. It's called aromatase. We block that one. Yes, it's called estrogen deprivation. Or we block estrogen receptor via tamoxifen. Or we degrade estrogen receptor by using a different drug. And we must do IHC for nuclear ER. It basically means cytostatic means it's not going to cure the cancer, but it's going to prevent the cancer from growing. Okay? Now, if CDKs are positive, this is an ER positive, and the patient is not responding very well, you give them an antibody to block the kinases. Kinases are the enzymes that are responsible for moving the cell through the cell cycle. And remember, we said the cell cycle is a very important component of cancer pathogenesis. So you block them. Our HER2 is here. You give if this is HER2 positive. HER2 positive can be from immunohistochemistry or by DNA sequencing or by in situ hybridization. If HER2 is positive, then you give antibody to HER2, or you can link cytotoxic therapy to HER2 antibody, or you can give tyrosine kinase inhibitors, or you can give vaccines can block the HER2. And this is normally effective if it's a HER2 positive cancer. Now, if you have BRCA1 and then you have other mutations or high-grade ER negative carcinomas, then you use what's called immune checkpoint inhibitors. High-grade ER negative. So the triple negative breast carcinomas and metastatic carcinomas that are possible, you use what's called immune checkpoint inhibitor. Basically, immune checkpoint is a way of making sure that the immune system does not just unleash their wrath on every cell. So they are meant to make sure that that does not occur. So what you do, like you have a dog, you have a very rabid dog, very angry dog. You cannot just allow it to roam around. So you tie it. You tie it with the checkpoint proteins. So that's the string. So if you have cancer in the system, what you do is you unleash the dog. You cut the immune checkpoints. You cut the leash. And you allow this immune system now to attack the cancer cells. That is the point of the immune checkpoint proteins. So you do proteins what is called PDL1 and PD1. Okay? They are very expensive drugs. Very expensive drugs. Before I go that, men can get breast cancer. Men can get breast cancer. Men can also get benign breast proliferation, one we call gynecomastia. The people with men breast cancer, age, genetic factors, family history, especially BRCA2 and BRCA1. Also in conditions where men are exposed to high estrogen, like Klinefelter syndrome, if men are given estrogen, yes, obesity, patient with orchitis or epididymitis, meaning they can't produce sufficient estrogen, or they are given blockers of androgen. This is gynecomastia, abnormal breast tissue which is benign in a man. We call it gynecomastia, and gynecomastia can be caused by any of these conditions we have listed here. That is gynecomastia. Gynecomastia is benign. Okay? Gynecomastia. Yes, you can have now the breast carcinoma. You can see this is a lesion in the breast. It has really eaten up the skin. And breast cancer in men have a much poorer prognosis based on the size of the breast of a man. A woman's breast is big and has some, so that by the time the tumor is reaching the chest wall, it has really advanced. But here, for a man, there's no tissue. Immediately you get breast carcinoma, it has eaten the skin and it's gone to the chest wall. So men should be checking themselves. Their breast carcinoma tends to be more aggressive, it tends to be more advanced because there's no sufficient cushion for the tumor. There's no sufficient breast tissue. You can see here there's a tumor here and it's completely eroded the wall. Completely eroded the wall. And this is like bilateral. You can see the same thing here. This is a really advanced stage carcinoma. And again, you can confirm, yes, this is a carcinoma. So this is a male breast carcinoma. Sorry for talking for too long, but these are two carcinomas or two cancers that we can't ignore. ovarian carcinoma and breast carcinomas. Those are carcinomas that we can't ignore. Any question as I leave you with this article?
Yes, for so fibroadenoma is very common, as you have said, in teenage girls,
Yes.
and most of them they are normally brought by their mothers, and the mothers are very worried because kwa ground they say whenever a woman has a lump in the breast, then they have cancer. So even when you try to give them peace and tell the mothers that this is normal, they seem not to agree, and they feel that something more should be done. Now, in such a situation, is it right for you maybe to recommend a mammogram, or do you have anything that we can do?
Oh, Kivali, I'm coming to your question. Mammogram is normally indicated only for women above 35 years. Mammogram don't do very well for breast that is dense. And teenage girls and young women have dense breast. So what we prefer to use at that age group before 35 is just the self-exam and ultrasound. Ultrasound is the best.
Okay.
And of course, once we do the ultrasound, we do fine needle aspiration. Fine needle aspiration is cheap. It can be done even in the office. It's less painful, and it's not as traumatic as biopsy.
Okay.
Okay. But I agree with you that we should be worried. We should be very alert. Breast carcinoma is a menace. It is too much. Take it from a pathologist who sees this almost every day. So if a mother is worried that her daughter has a lump, I would encourage the mother to be worried so that we review it, we confirm, no, this is just normal, you can relax, or you can go for excision. If it is less than 2 centimeters, you don't need to excise it. We can always, once we confirm this of adenoma, we can always follow it up with a subsequent imaging. Now, Kivali is asking a very good question about finasteride. In men currently, finasteride we use it mainly for benign prostatic hyperplasia and also for prostatic carcinoma. Yes, it's normally it blocks androgen receptors. And as Kivalia said, should we be monitoring patients taking finasteride, or should we explore other drugs for androgenic alopecia and the rest? Well, finasteride is still very good, but I think there are now newer drugs. Depending if a patient has, for instance, benign prostatic hyperplasia, and by ultrasound or by histology, we can confirm that it's mainly the stroma that is high, then I'd rather we give the smooth muscle relaxants. But for men, if you have to use finasteride, it's good to monitor to make sure that they check their breast, because yes, that is a risk factor. You start with gynecomastia, and then you move to a breast carcinoma. Because the key word here, Kivali, is that most of the breast carcinomas are estrogen driven. So anytime you have excess estrogen, like in a man, because you are using finasteride to block the androgen effect, you can get that. The risk is there, but again, I'm going to tell you, like any other doctor, you have to weigh the risk and the benefit. Now, this story is sad, but this is the Kenya. And again, we have said, if cancer is HER2 positive and you don't give Herceptin, the chances of distant metastasis, the chances of relapse is extremely high. And you are seeing the cost of Herceptin. You normally are supposed to give 6 cycles. And you can see this is 2023. She's talking of needing 330,000 for only 3 cycles. I'll stop there.
Doc, can you
Yes,
help
ma'am.
me appreciate when a patient presents and you examine the breast and you're likely to, he has the features of carcinoma. What is the process? Because I've also the episodes of actually now complete management. Because also I've seen that sometimes it takes very long time for us to either get it, do the markers, and be able to diagnose exactly and put the patient on treatment. And sometimes also I've seen we lose patients. What's exactly on local? What we do when when or what, how can we help this patient who are presented and they have these features to ensure that we're able to get the management of this patient faster and help this patient survive?
That's a very good question. Now, the local setting, I would say, I would use two characteristics. I'll use the age and I'll use the features I see on a patient. For instance, if a patient comes 22 years old, there's a mass there. It's a very mobile mass. It's discrete. There's no skin changes. There's no nipple discharge. There's no axillary lymph node. My first thinking, this is fibroma. So what I'll do, I'll order for an ultrasound and then do a final aspiration. And if it confirms there's a fibroma, two options. If it's a small, more than 2 centimeter, we monitor. If it's more than 2 centimeter and the mother and everybody else is worried about it, we go for simple excision. End of story. Now, scenario 2, a lady comes around 35 years. Now there's a mass, there's also some pain, there are skin changes, she has an axillary lymph node, there has nipple retraction. Then my first thinking that this is a carcinoma. I do ultrasound, I do mammography, and then I don't do now final aspiration. I do core needle biopsy. Do core biopsy. And from core biopsy, if it is cancer, we'll see the carcinoma, the histology, and then we'll do the markers. We'll do the IHC, we'll do the ER, we do the PR, we do the proliferation index called Ki67, and then we do what's called HER2. And once I've done HER2, now based on that, you send we have confirmed this patient has carcinoma. We do what's called staging. So we do abdominal ultrasound, we do CT scan of the chest. Yes, sometimes typically it's just abdominal ultrasound, CT scan of the chest. If there's no metastasis, yes, if there's no metastasis in the chest, there's no metastasis in the abdomen, then these are candidates for either surgery and also for chemotherapy, depending on now their ER, PR, Ki67, and HER2 profile. Of course, there's the issue of the staging. When I'm staging, I want to see how far that tumor has gone. If there's metastasis, I can't do surgery. Surgery is off the table. Now, if this is an advanced tumor, we are talking about tumor that's invaded the skin, it's very large, there's an ulcer, the best way would be to give chemotherapy first, what's called neoadjuvant therapy, and then go for surgery. And then after surgery now, we add you additional now. If it is ER positive, we give you the tamoxifen and the rest. If it's HER2 positive, like for this case, now we give you Herceptin. Okay, I would use the clinical features. I would use the imaging characteristics. I'll use the age. I'll decide on whether I'm doing ultrasound, FNA, previous review, then subsequent reviews, or I'm doing a core biopsy straight. If I'm unsure, I'll do a core biopsy.
Thank you. Locally, so for AR, PR positive, we have said that you have seen that you can do a oophorectomy. Now, do you have cases locally where this has increased the prognosis of the patient?
If the what is positive?
If they are AR, PR positive carcinoma, and you resect the ovaries.
Yes.
Do you have any cases locally where this contributes to better prognosis?
Yes, it does. I don't have the data with me here, but it does. What it does, it is normally what you call cytostatic. It makes that if there is any other tumor that has not been resected, that tumor does not grow. Because the growing of these ER positive carcinomas is based on the presence of estrogen. And this is what will give you that long survival. Remember the long survival we are showing here. Sorry. This long survival that we are showing here. Where was it? The long survival that we are showing here. Low rate over many years and long survival possible is because of the limiting estrogen. Tamoxifen is easier than doing oophorectomy. The problem is that tamoxifen can give you other problems, including endometrial carcinoma. That's the catch. Yes, but yes, the long prognosis, the better prognosis we are seeing in estrogen positive carcinoma is because we are giving a tamoxifen. Kivali is asking, why do some lactating mothers have a different size of the breast? Kivali is just engorgement. You see, when you're breastfeeding, you have to express milk from both sides. If you don't, then one breast becomes engorged. It's basically a form of engorgement. So like the mother is preferring to lactate only from the right breast, the left breast will engorge and become larger. If you express the milk out, the size will just be the same. But Kivali, also remember, breasts are normally not equal sizes. They might have been born with one breast slightly bigger than another breast. That's a normal anatomical variation. Any other question?
Doc, my last concern is that do you have anything that we can put on our finger? Because we have said these cases are really increasing. Breast cancer is actually becoming very common. Even at family level, these cases are presenting. And do we have any factors that we can say, for example, in our setting, that could be contributing to this increasing cases? Or is it that maybe our diagnostic aspects are becoming better than before?
You could say that, but there's also the aspect of our change in diet. Our change in diet is something that needs to be evaluated, especially moving from our usual traditional food to a diet that is heavy in carbohydrate, a diet is very heavy in fat. And the issue of obesity and breast cancer, that one is a well-known fact. It's a well-known fact. Okay, we would need a large-scale model research to actually confirm that, because again, the problem again with the research is normally you have to very, very well link cause and effect, which Gitao, I'll have to admit that is tough for what we do currently. We have not typed our cancers very well. We have not done a very nice genetic modeling. So we don't know whether we were born with those mutations or we are acquiring these mutations, or is the diet that we are having, or the changes in how we manage our pregnancies. Okay? Breast cancer, again, very common in patients who have a low parity. I know what. I hope you know what I mean by low parity.
Yes.
Yes. So that because we are not having very many children, could that also be a factor? But I would say we need a really large scale properly model research for that.
Thank you.
Excuse me.
Yes.
My last concern. Okay, this is my first one. So according to this study, do we have data that shows if this woman got assistance?
Oh, this particular one.
Yes, yes.
No, this is an article from Nation newspaper. You can see it's an article. It's actually an extract from a Nation newspaper.
Yes.
So I'm not sure how it went down.
Okay, thank you.
But I have a feeling it's not surely very sustainable, Timothy. It's a very difficult process, a long journey. Recurrence rate for this breast cancer tends to be very high. And the moment you stop treatment, even for a month, it comes up aggressively. This cancer, if you don't give Herceptin, the outcome normally is not very good. It's a sad case. I just show it here because it's a sad case. But that's why we are. And that's why I didn't want to bore you down with the details of histology. I wanted you to see how we manage these patients and what are the criteria we use and how difficult it is to actually manage these patients. You had a second concern.
No, that was the only concern. Thank you.
Okay.
Just last week, the case of gingimastia in young girls. Last week in Kenyatta, they exercised. There was a lady. The gingimastia. Gingimastia. In Kenyatta last week. Yes, the large breast. They did a lady, a female of 16 years. They exercised the largest mass. They are saying in history, 26 point something kgs, and which was contributing to about 37% of the weight of the girl. And that was, for me, it's just was just phenomenon. I don't know how that led, how it was she was surviving.
That must have been very tough for her.
Yeah, that was a very interesting case, and these cases are in our community. So I'm really appreciating today's lesson.
Yeah, it is. I think it's also becoming common because again, there have been stories of estrogen leaking to even the water we drink, even the food we eat, even the types of food we eat. So this could be a problem also. I'm seeing a lot of it. I agree with you. It's not a very uncommon lesion. Okay, not a very uncommon lesion, but it's 6 kgs big, and that can give you a lot of really severe backache. Really severe backache. Yes, this is gigantomastia, but this is a slightly older age group. The one we are talking about most likely is this type, pubertal macromastia. But it's giganto when it is this. When it meets this criteria, then as Gitawa said, the term we use is gigantomastia. Any other question? Sorry, I've taken a lot of your time. Allow me to stop there so that now you can prepare for the next lesson. Faith, I'll remove most of the pictures that I give you. I put in more of the notes for your reading, then I'll share the notes. Okay.